I think. Well, I'm supposed to stay on kind of this side of the room for the recording, so I'll try to remember to do that. I am a walker. Do like to move around, but I'll try to kind of stay on this side. So you guys are safe over there. I am Shelley Seslar. I work at North Central Educational Service District. I've been there 26 plus years, and working as managing director of Behavioral Health Services. So thank you for the privilege of presenting you guys. Really exciting to have a like-minded group to talk with. Often I am talking with folks from our school districts and our school personnel, and I get an opportunity today to talk with folks who work in the community. And that is really special for me, and actually a really great opportunity to have that lens to talk to them. So, however, since this is a new presentation for me, I do have this sort of scripted out to make sure I actually cover the things that I want to cover today. So apologies, I may be actually looking at my script a little bit today more than I usually do when I give a presentation to school folks, where I can kind of almost do that in my sleep a little, not quite, but you know what I mean, like I've done it before. So anyway, so apologies for that. So as I look around the room, I do see a lot of leaders, and I know in listening to this morning's presentation, meeting with some of the more veteran faces that I remember from years past, that you guys are the leaders in your community, whether you work as line staff or advocates, volunteers, executive directors. You are leading the work with the people that live here in your communities, whether it's in Grant County or in regions outside. And we do in North Central ESD serve the 4 county regions, so I can kind of speak to all of our 4 counties, at least Okanagan, Grant, and Shelley. And so I really welcome you. You're the leaders of the safety net. You're the directors, the clinicians. You step in when life gets heavy for our young people. And in my role for over 26 years plus in this work, I've watched our systems evolve and change a lot over time. So today I want to talk about shifting our focus from just a safety net to catch youth after they've fallen or experienced difficulties, to instead being the foundation that prevents that fall in the first place, or catches it as early as possible. We know prevention isn't happening at one time or in one place or in one setting. Prevention is kind of all around students, or should be all around students. We have the opportunity to wrap around students with prevention and youth. Sorry, I'll probably talk about youth as students a lot because that's my career, but so translate that into youth. At North Central ESD, we think of prevention in sort of a social ecological context. So what does that mean? A layered approach that children's mental health develops inside themselves individually, but with their peers, with their family, in their neighborhoods, in their larger community, at school, of course. So that's all of us. That context happens everywhere and with all of us. So that means we all have an opportunity to be part of that at all times during their development. And since today is about connection, I'm really excited about the theme of today. That's what I want to talk about, is how can we strengthen the connections and make sure that prevention is happening more robustly and more regularly. I'm sure you know why this is important, just really briefly to ground our conversation. We understand this problem can be urgent for our students. This is just some data from 2023, a Healthy Youth Survey. We are about to get the 2025 data out, so that's pretty exciting. But from 2023, our students told us that roughly 30% of our 8th, 10th, and 12th graders reported feeling so sad or helpless every day for 2 weeks that they stopped doing their regular activities. That's what they told us. We asked them and 30% of them, 3 out of every 10 students that sat down and answered that question said they had stopped doing their regular activities because they felt sad or hopeless. That's pretty compelling. And an indicator that they are probably experiencing some depression. If a virus were affecting 30% of our children and causing them to stop doing their regular activities, that would be a pandemic or a major emergency, right? So I think this is very urgent. In behavioral health, we can tell that is an emergency that is here. Even more alarming then, but understandable in context of 30% of students suffering in this way. Between 12 and 16% of students in grades 6 through 12 seriously considered attempting suicide in the past year prior to being asked this question. That's what they told us. So that's 1 to 2 students out of every 10. 1 to 2 kids out of every 10, grades 6 through 12. So we cannot afford to only wait for these students to come to us in crisis. Instead, we need to focus on youth prevention and building protective factors around them all the time to become that foundation I mentioned earlier. Of course, we're doing that, but we just want to focus on really strengthening that foundation in our Gregg County and in our surrounding neighborhoods, in our schools and neighborhoods. Regarding protective factors, in that same healthy youth survey, our local data showed that about 63% of students reported having adults in their neighborhood or community that they can talk to about something important. That's a start, but that means that 36% or so don't have an adult they thought they could talk to about something important, and we really need to make sure that they do. It means they are completely invisible or feeling invisible to the adults around them in terms of what's really matters to them. So one of the goals of prevention should be bridging the gap. Those critical community protective factors to wrap around students. And by the way, you heard this morning from one of our presenters about the healthy youth survey data. All of you can right now go to the AskHYS.net website and find a dashboard there to investigate data that matters to you about what students are telling us in Gregg County. And like I said, the 2025 data is about to come out. It's really exciting to get to see that new data. And you can find lots of important information. It's one of the only ways that we get to hear from students about what their lives are like in a really reliable way. So great resource. All right, the big picture about prevention and early intervention. I wanted to say a few words about how we in schools view prevention frameworks and how in public health you might view them, and how our vocabulary sort of differs, but is really a lot the same at its heart. So in schools, we talk about what's called the NCESD framework, which stands for multi-tiered systems of support. So maybe you've heard of the multi-tiered systems of support framework, maybe you even use it in your organization, which would be great. Sometimes in public health, I think it gets called or termed a prevention curriculum, or not curriculum. See, look at me, I'm so school oriented. Continuum, prevention continuum, where you have primary, secondary, and tertiary prevention. Okay, but very analogous. So in schools, tier 1 in that multi-tiered system is for all students. It's the universal things we do for all. And so when you think about behavioral health, it might be things like social skills or social emotional learning curricula. There are things like character strong, sources of strength, lots and lots of really good evidence-based curricula. The K-12 health and fitness standards have requirements, what gets taught at every grade level in terms of health education. It's another place where you can think of tier 1 behavioral health, mental health promotion going on. And so in Grant County, only about 52% of 8th and 10th graders said that they agree that they know how to disagree without starting a fight or argument. That's one example of a social emotional skill. So only about half of students in Grant County said they know how to do that. They felt confident in their ability to disagree with someone without starting a fight about it. That's one example of where a protective factor for students may not be robustly being built for them or developed. We really need to do everything we can to strengthen tier 1. Okay, moving on in the multi-tiered system of support, tier 2 is for some students, you might have heard it called secondary prevention or selective. And it's where we provide early detection and interventions for students who are experiencing mild distress. And in schools, we use things like psychoeducational curriculum. One we use in our programs are trails. And there are others. One you might have heard of is Teen Intervene for substance use. And then tier 3 is those more intensive interventions that are needed for problem management or treatment. And that might happen in a clinical setting, so it might require an external referral out to your organizations, or it might happen at school. But the point is, it's just for a few kids, or we hope it is. We're doing a good job at tier 1 and tier 2. The better job we do down here at tier 1 and tier 2, the less students are going to make it and need tier 3 types of interventions, we hope. That's what we see. Okay. So there's broad similarities between the public health model of primary prevention that focuses on health promotion, campaigns and things like that, and secondary prevention that focuses on early detection in public health, and tertiary prevention, which focuses on treatment models and chronic management of disease. And our school system, which has a slightly different terminology and vocabulary, but is still really analogous. Sometimes though we get confused. That's what I've noticed in my career, working with schools and public health systems, is that we get confused about what each other is talking about. So I did want to make this point. Share our different languages. And I want to put in a plug. So at North Central ESD for 20 plus years, we've had a program called Student Assistance Program. We are lucky enough to be able to support right now 4 SAPs in Grant County. We have more around the region, a few more. Grant County is actually our highest penetration rate, I guess you'd say, of SAPs. We have 4, as you see there, Quincy, Ephrata, Soap Lake, and Moses Lake. Pretty lucky to have that kind of capacity. However, it's not enough, you can imagine, to cover each one of those SAPs at full time serves about 50 students individually. And of course, they do some school-wide tier 1 sorts of activities, but that's not enough capacity for what our system needs. They work alongside other professionals, probably like yourselves. Who's heard of SAP program or worked alongside SAPs? Great. So some of you have. That's wonderful. And of course, they work alongside you all. You can see our SAPs do have a proven impact. I put that up there to toot our own horn, sure, yes, but also to point out that a program working in the multi-tiered system support framework in schools or in communities, doing some tier 1, but a lot of tier 2 sorts of work has a really big impact. So in your agencies, you're probably working, in your tier 1, 2, or 3 sorts of areas, and you too are probably having really big impacts. What I've seen in my career is it's the tier 2 sort of early detection, early intervention that maybe doesn't get enough attention. And tier one as well, I will say, that's hard as well, to get enough, and it's kind of one of the first things to go when budgets get tight, time gets tight. The tier one universal kind of activities, curricula can get put by the wayside. But the more we can do of it, the more we're reducing problems down the road. Okay. I'm doing a horrible job of following my script, by the way. That's okay. It's just not me, that's good. I do want to make a point about crucially our SAP staff who work really hard to reduce stigma in their school settings, and I think they do a really good job of opening doors to students to come talk with them about problems they're having, which then leads to more referrals out when needed and appropriate to resources they might need, services they might need, maybe clinical assessment in the community. So this is really what I wanted to get to today. In terms of prevention and early intervention, and tier two practices of early detection. If we agree that early intervention is a goal, that we want to catch students before they reach a crisis, before they've spent years struggling and suffering, how can we do that? We have to ask, how do we find the kids who are hurting the most? And traditionally, we've waited for students to act out or disrupt a class or fail a grade or raise their hand and say, you know, something to us. But that is reactive. That is not proactive, is it? And I think we should be proactive, and I think we're doing ourselves a favor and of course students a favor if we do that. So it brings me to my call to action today that I really want to talk to you about. How do we accurately identify which students need tier two? Well, universal mental health screening is a growing evidence-based practice nationwide that we aren't really using much in our region, in schools at least, that I'm aware of. So who's heard or read articles about or experienced universal mental health screening in some ways? Really just a couple? Okay, well, that's what I mean. I think it's a foundational missing practice and why I'm really feeling privileged to tell you about it today. I think we need more focus on this in our settings, especially at schools. And I talk to schools about it, but I want to tell you why that can be really hard for them. So mental health screening gets to the heart of early diagnosis and recognizing warning signs. The U.S. Preventative Services Task Force, yes, there is such a thing, has said that they explicitly recommend screening for anxiety in our youth, beginning at the age of 8 and continuing until the age of 18. So just like we get screenings for mammograms and colon cancer and et cetera, that's what the U.S. Preventative Task Force is in charge of recommending, things like that. Well, they're also recommending screening for anxiety starting at age 8. They're also recommending screening for major depressive disorder in adolescents starting at the age 12 and continuing through 18. How are we doing that? When is that being done? So we go to our PCP and we get, you know, our primary care physician, we get asked to go for our mammogram, colon cancer screen, whatever it is, at certain ages. Are we also getting screened for anxiety and depression on a regular basis? Our children are. Well, in schools, we routinely do screening for vision, scoliosis, hearing, things like that. We can also routinely screen for emotional distress, anxiety, and depression. We need to do that in the same way. It reduces stigma. It treats mental health just like physical health. It works. It's a trauma-informed practice. It recognizes that many students carry their burden silently, and they're not going to raise their hand and tell us what's going on until maybe it's too late or they've been suffering a really long time. Our screening data shows 60% of a ninth grade. What I want to say is, universal mental health screening can be good for recognizing individuals early and their suffering, right? But it can also tell us about the environment of a school and the culture, or not the culture, but the climate in a school. If we find that 60%, for instance, of a ninth grade class is suffering from a high level of anxiety, well, are we going to send 100 youth to treatment for that? Or should we instead bring services to the ninth grade and wrap around what's going on, what's the root cause? Bring more into the school to treat that. I would say would be more efficient and effective and proactive, treating that as an environmental issue. But either way, we can treat individuals, we can treat a whole system, but data is important to have. So in our region, we have a regional lighthouse school, I'm going to call them, Wenatchee High School. They have been doing universal mental health screening since 2018. Right before COVID. Was before COVID, they did their first event. I'm looking at Crystal over here because she was part of the community partners that came in on campus for Wenatchee High School's very first universal mental health screening event. I got to assist Wenatchee High School in their early planning stages for that event. It's quite a privilege, and they have continued doing annual universal screening of their 9th, 10th, 11th, and 12th graders ever since. They started with just their 9th graders, and then they've continued it, they've expanded it, and they've just institutionalized it. And they've brought in their community partners, which one has to do when doing universal mental health screening, because you need to have community partners on board to help you with the inevitable students that are going to screen in as needing assessment or needing services right away. But why aren't more schools doing this if it's such a good idea? Why aren't more schools doing this? Yeah, let's get mad. Don't get mad at schools. Don't get mad at schools. There's reasons for that. Schools frequently report roadblocks, such as concerns over liability. They're concerned if we ask the question and we find out students are suffering, then what? What are we going to do? And we're a school. We teach kids. We do have some counseling services. Maybe we're lucky enough to have some social services, but we only have so much capacity. So there's the liability. There's also an administrative burden. How are we going to handle consent? How are we going to set up the screener? How are we going to score? There's all that. There's a high level of fear of uncovering a high volume of student need and not knowing what to do next with all these students who are in need and overwhelming their own student support services. So here's my ask. We can ease the administrative burden by, using a passive consent model, things like that. I can help schools with screening tools and scoring methods and all the nuts and bolts logistics of the day. But to address the overwhelming need and the fear maybe of parental pushback and things like that, we need the community. We need the community on board. And that's where my ask is to you guys today. My ask is to find out more about universal mental health screening and then be an advocate with your schools for this idea. Okay. All right, so moving on from early detection, I want to say a little bit about in our program how we're intervening with students. Have you heard about SBIRT and MI? Who's heard of motivational interviewing, first off? I've got a good number of hands, that's awesome. So motivational interviewing, definitely a foundational approach. Thank you, definitely a foundational approach. It is perfect for adolescents. If you're not aware of motivational interviewing, you're not utilizing that as an approach, maybe in your direct services. I think anyone who works with adolescents really would benefit from having good knowledge of how to use motivational interviewing strategies and talking with students. And the reason is that it is a non-confrontational approach that meets people where they're at, whether they're ready to change or not. And that's quite often our adolescents. Could be humans, right? Often adults too, but it's definitely adolescents who come to us. It also gives them more autonomy over change and what they want to change. And that's great for adolescents too. They're looking for that engagement in their own, not being told what to do, frankly, by the grown-ups. So motivational interviewing is great. And then SBIRT, who's heard of SBIRT? Nice, nice. Love that there's more. Okay, SBIRT stands for screening, CS, brief intervention, and then the referral for treatment. Super simple, but it's a great model. You first screen, first find who needs help. Second, have a menu of brief interventions that might help those people you're screening things about. And then have a robust referral pathway and a warm handoff to those treatment services or social services that people need. That's it. That's it. It's not rocket science, but it's good to have a strategy and a roadmap for where you want to go. So I think MI and SBIRT combined, along with a robust universal mental health screening, we got a plan. Well, that and the money to pay for the services. Yeah, that's pretty key. And I want to say a word before I end and I hear from you about your thoughts or questions about reducing stigma, and just a word about what really seems to work, or a few things that really seem to work that we found. And one of them is just really peer-to-peer strategies, letting students or youth, sorry, talk with other youth about their challenges. Can really lead to them opening their eyes about other people have these struggles too. My peers think it's okay to talk about this. It just opens up the conversation. So we can support, all of you in the room can support things like youth-led clubs, youth advocacy, youth drop-ins, youth places for youth to be engaged and talk with other youth about mental health, behavioral health, substance use, and things like that, so that they can be talking about the solutions together. I heard a murmur in the room about the North Star Initiative and how they're going about using peers or youth voice to lead their project, and I'm absolutely with you. All right, just to wrap up, I think I've said enough about the universal mental health screening. My call to action, really, I want to lean on that. I am, as a behavioral health navigator, here to help our schools and also our community. So in my role, I serve as something called behavioral health navigator at our ESD. And my role is to serve between the schools and the communities as a behavioral health partner and be kind of a liaison between you. So please reach out to me if you would like some help working between your agency and organization and schools. And I would love to help. So if you're like, I would like to work with my school about this, let me work with you. Make that happen. The other one is something you may not know is that schools have an RCW in place that requires them to have at least one memorandum of understanding with an external organization. That could be your organization. And that MOU is supposed to, as you see here, establish clear referral pathways. It's supposed to prepare for students who are in emotional distress. So that is an opportunity for organizations in this room to strengthen your preparedness with your school, strengthen your partnership with your school. And that is another area I can help you work on if you would like. And then lastly, protective factors. Just keep doing what you're probably already doing, but know that schools need your help in wrapping around students and building those protective factors we've already talked about. Okay. I am really excited here in the time we have left, about 10 minutes. What thoughts you have? Or questions you might have about universal mental health screening, or protective factors, or how your organization is going about your work? Are there opportunities you can think of to maybe build some of these calls to action, or build on some of this work, or partner together? Any thoughts or questions?
So, I work at the community health. And so we get a lot of students that are looking for ADHD and autism screenings and assessment. And our PH team can do kind of the basic screening for ADHD, but not for autism. And so then we get a lot of, we see about, in the school, we'll provide that psychological testing. But we don't have like a good relationship with the schools, and there's not a lot of outside agencies that offer those screenings for autism specifically. That's big for us.
That's a gap. And I don't know a ton about that, but I'd be happy to dig into it with you.
I think there's only one doctor in most slavery.
Yeah. Yeah, I know it's a missing piece, and there might be Wenatchee, already going to Wenatchee, some folks
Yeah.
headed to Wenatchee and other outlying areas, but yeah. Yeah. That is an example of a good example of screenings that are needed. Are there other, who's doing screenings in this? Are you doing? I'll call them universal, but they're probably, schools are a place where we can actually do universal screenings. We can like all students get it. Anybody else doing screenings?
The pediatricians in Moses Lake are, I think some of the family practice are too, but it's not universals.
It might be universal for the kids who come in though.
For
Yeah,
their practice.
the families.
We have one that does screenings, but to go through like autism and really get it, it's not true.
No, not for autism. And autism one, we might not do a universal screening, or if it was a screening, it would be like just a one question screening or something. It would be like, non-assessment.
Do you have a list of universal mental health screenings that you use that are age appropriate?
I do.
I mean, like, I know the PHQ-9 has age limits and, they have, whatever, there's lots of them, they're out there, but. I mean, you just kind of said the broad umbrella, but it's like, I'm curious, does Wenatchee, I've actually talked with Bob. And does Wenatchee utilize mental health screenings down to the elementary schools? Or is this just something they start in middle school or high school? Like, when do you start this? What are the age appropriate?
So all that is negotiable, right? A district or school can make those decisions along with their community. And it depends on capacity and what they decide to do and what they decide to screen for, frankly. So, they might decide anxiety and depression and suicidality are just what we're going to screen for, but they might also decide, well, we're interested in some other things like, anyway, some other things. Anyway, substance use, for instance, or something like that. There are numerous, and I do have a compendium of types and reliable instruments going down into elementary that could be used. But it all depends on the will and decisions that are made, and they should be made in partnership with community partners, because as soon as the instrument is given, then we have to do something with the information. And usually that's going to require some partners with us alongside. Some of the students will be served at school only, and some will be served with our partners. They'll need more intensive services. So it just depends. It's kind of, it's open. What do they want to screen for? But if we don't ask, we won't know. And what I always say is, yeah, you know, it's scary to think there might be a ton of kids that say I'm suicidal. But they walked into school this morning that way. And we didn't know it at all. And if we could find that out by lunchtime and do something about it, we should do that. But we should also be really prepared.
I have another question. What's the school district's responsibility to the parents at that point in time with the information that's gathered? Because again, kids over the age of 13 have a right for mental health services without parental involvement. But if we have kids that are reporting suicidal ideation or suicidal thoughts, and we have gotten the community on board with, do you know where I'm going?
Yes,
with
I
this?
do.
We got
So let me-
the
yes.
parents on board.
Yeah, let me
Yeah,
answer
we
that.
got this great information, but now we're not gonna tell you what the kid said.
So here's how we handle that, and here's how that can be handled in a school setting. Schools work under FERPA, not HIPAA, so the 13th thing doesn't apply to us. We communicate with parents up to the age of 17 through 17, till they're 18, about the students, probably while they're still on campus, so even 18-year-olds. We don't know the answer to that. Were they calling 18-year-olds parents? Yeah, in your experience, it's kind of a gray area, yeah. Anyway, so the school is administering the instrument and the community partners don't need to worry about that data collection and that HIPAA compliance. Because it's under FERPA or right to privacy. So the school staff are calling parents if there's a concern and letting them know that. What the community partners are doing then with their HIPAA compliant information is they're doing their work with those students who then get referred that day immediately. Or maybe in the week or two that follow, they're just going through their usual process as they normally do. And if the students are under 13, they need parental involvement. And if they're over 13, they could do it on their own, but usually parental involvement if you can get it. And that's how that works. So the record keeping at school gets kept at school and the record keeping at the community partners gets kept there. Does that make sense?
Yeah.
And it works. But it brings up those conversations need to be had before the event. So it takes a few months to get that off the ground. Yeah. Love these questions. What else comes up for you? Yeah.
Have they done these, like surveys, have they done the screening like anonymously, so the students feel more comfortable saying maybe
No, the screenings need to be done
put their name on
with
it?
their name on or their ID number, or it needs to be identifiable, because if the student says they have a high level of suicidality or depression or something, the point is to get them supports. So these screeners are identifiable, and students are told that ahead of time, that their answers are going to be identifiable. The Healthy Youth Survey is different. Things like a survey are different, and those are not identifiable. Those are confidential and anonymous. And students are asked questions like, are they suicidal, and have they had suicidality, or ideation? And in those cases, we can't track back to who said that. That's why it's important in screeners that we can identify student and respond.
Yeah. So the survey would be like in a tier 1 basis. It follows her.
The survey,
Yeah.
in the case of Healthy Youth Survey, if we find out there's a large number of, say, kids with anxiety or kids, that were suicidal, we would do interventions more in a tier 1 and tier 2 way, where we're trying to, like, oh my gosh, we have a problem. We don't know which kids said this, but a lot of kids are telling us that they have problem behaviors developing, a dysfunctional issues going on that we're concerned. Yeah, Nancy, yes.
So I happen to be on finance.
Hi.
I happen to be on the board for communities and schools, and I'm wondering if this isn't a conversation that should be had between ESD and communities and schools, and maybe you've already started that
I
conversation.
haven't at all, Nancy, that's cool.
Because, you have people like in those schools
Uh-huh,
and doing some of those tier types of work.
yep.
And so how it just, I think would be a good conversation about how that partnership might expand the work within the schools.
Oh, I love it. Yeah, we're running out of time, but that's the gem I got out of one that I got out of today. I hope others got gems out of today. My contact information, I'm gonna talk to you about that. My contact information though is on this handout I handed out. If you need one and didn't get one, it's up here. And I think I need to let these guys go. Did you have
Yes.
something to tell them?
So we have lunch from 11:40 to 12:40, but the lunch will be provided, it's over here, right, lunch that way. Yeah. And yeah. That's,
Okay, well, so lunch, I don't want to stay between you guys and lunch.
yeah, and
I
then
am
also
excited.
during lunch, there's gonna be like a little media resource fair, like the one who got the latest.
Thanks for coming, you guys.
And then I'll screen it.
Oh.